Hi, my name is Dr. Stephen Levenson. I'm a member of the work group that has developed and refined the Maryland MOLST order form and related documents and materials. The past 3 decades have seen extensive political and social debates about bioethical issues, including individual rights to document healthcare treatment wishes and to have those choices honored. However, relatively few individuals have made advance directives or living wills. In addition, the shortcomings of such documents have been identified. For example, it is difficult to anticipate in advance the kinds of situations that might arise many years in the future. In addition, there are challenges of getting wishes honored and interpreted consistently. So, the idea of a portable, enduring order form for life-sustaining treatments, the MOLST concept, began in Oregon in the 1990s and has since expanded to many other states. In 2011, Maryland is implementing its version, the Maryland Medical Orders for Life-Sustaining Treatment, or Maryland MOLST form. It incorporates the Maryland Institute for Emergency Medical Services Systems Do Not Resuscitate form and its related procedures. Overall, this training program focuses on key aspects of the new Maryland MOLST order form, including specific requirements for completing, using, storing, and transmitting the form. Ultimately, however, the MOLST form is just an order form, a tool to help write standardized and understandable orders related to life-sustaining treatment options. As with any tool, it has the potential to make the job easier for those who understand how to use it correctly and safely. But in contrast, it also has the potential to cause considerable injury if used incorrectly. So this session covers the healthcare decision-making process that is the foundation for optimal use of the MOLST form. Many of you are familiar with this process and have applied it successfully over time. Others may need to review and revamp their current approaches. Let's consider the key steps in the healthcare decision-making process and other related issues. We continually have to make healthcare decisions under challenging circumstances. Only some situations have clear-cut options. As this slide illustrates, we still have to decide even when none of the options are ideal. We know that patients and healthcare professionals alike vary in their willingness and ability to make these complex decisions in the face of uncertainty and incomplete information. Use of the healthcare decision-making process can help us organize our approach and identify and use relevant information even in the face of uncertainty. Recognizing these challenges, the MOLST project has developed forms, information, resources, and guidance to help you address the challenges. You will hear about these resources during the day's training session, and you can view them on the MOLST website. This slide lists some of the challenges that we all face in trying to make the best possible healthcare decisions. First of all, good decision-making takes time, but we don't always have the luxury of time. In some situations and settings, we have days or weeks to gather information and make decisions. But in an emergency, for example, when EMS personnel are transporting or assessing an ill, unstable patient, there may be only minutes. Secondly, healthcare decision-making is a fairly complex process that is best done systematically, to the greatest extent possible, and within the available time frame. The availability of key information, such as a patient's documented wishes and the identity of the appropriate authorized decision-maker, can help those who must make the decisions and write the orders. Skipping critical steps or making decisions haphazardly without understanding and using available information may be problematic for both the patient and the provider. Another challenge is the availability of individuals who have the knowledge, skills, and experience to perform tasks such as determining decision-making capacity and presenting treatment options. A related challenge for organizations and facilities is to be able to assess staff and practitioner performance of these tasks and to improve such performance as needed. Yet another challenge is the concern or fear about legal and regulatory implications and possible complications related to making healthcare decisions and writing orders. In this regard, it is helpful to read the Healthcare Decisions Act to understand its requirements and implications and to interpret its provisions for those who make decisions and write orders. The Healthcare Decisions Act and the regulations related to using the MOLST form provide significant explicit legal immunity for those who act in good faith and follow related procedures. So, adherence to the healthcare decision-making process, as discussed in this session, is consistent with these laws and regulations, and it should help to minimize legal and regulatory complications. The MOLST form and its related materials have been designed to facilitate and streamline compliance. For example, the MOLST form incorporates the MIMS Do Not Resuscitate order form and allows a single order to apply both in the setting where a person resides or receives care and when EMS personnel are involved in providing care for that individual. Since MOLST is standardized and portable, it should help to reduce duplicate work as patients move across settings. By providing standardized specific treatment options, it should also reduce the time that practitioners need to document pertinent orders. So adherence to the healthcare decision-making process can be beneficial in several ways. It helps to organize a complex topic so that the end results, the MOLST orders, flow logically from the preliminary information. It can reduce confusion and conflict that often lead to preventable complications and a less satisfactory result for the patient. In the long run, it promotes more efficient use of everyone's valuable time, while cutting corners or skipping steps often leads to spending more time trying to straighten out the complications or having to redo the steps. Process adherence also helps make the most and the best use of the limited number of individuals we typically have available to do these tasks. Greater consistency means that information and orders can be more readily utilized to guide subsequent decision-making across settings. Consistent and correct use of the MOLST form and related decision-making processes facilitates legal and regulatory compliance and can help prevent expensive complications. And finally, adherence to the healthcare decision-making process can demonstrate to both patients and professionals important principles about complex decision-making that can have potential benefits for other aspects of care above and beyond consideration of life-sustaining treatments. This slide and the next one summarize the key steps in the healthcare decision-making process. In your handouts, along with the slides, you will see a one-page flowchart that presents the steps graphically. The remainder of this session reviews these steps in more detail. Keep in mind that the exact sequence of these steps is flexible. For example, sometimes it will be necessary to make a decision in a hurry or despite missing or complete information about the cause of a change in condition or the likely prognosis. Or sometimes we will already know who the primary decision maker is, but we won't necessarily know what the condition and prognosis are. But the idea here is to assemble the available information to the greatest extent possible to allow for review and possible revision of orders when we get down to the subsequent later steps in this process. So step number 1 is to identify situations where discussion of life-sustaining treatments are needed, and also to identify those who wish to discuss these situations and treatment options. Step number 2 is to identify, obtain, review, and start to clarify the content of existing care instructions and previously made decisions, including existing MOLST orders. It's also a good time to begin to clarify the patient's values, goals, and wishes. Step number 3 involves clarifying relevant medical issues, including the patient's medical condition, prognosis, and mental and physical function. Step number 4 is to define and try to optimize the patient's decision-making capacity. And step number 5 is to identify the primary decision-maker in accordance with the sequences prescribed in the Healthcare Decisions Act. Step number 6 is to certify the presence of qualifying conditions as appropriate. Step 7 is to define and discuss life-sustaining treatment options with the patient or appropriate authorized decision-maker on behalf of a patient who lacks healthcare decision-making capacity. Step number 8 is to document and implement the orders related to life-sustaining treatments using the MOLST order form. And finally, step number 9 involves recycling the process and reviewing and updating MOLST orders as needed. Let's consider each of the steps in more depth. An early step in the healthcare decision-making process is to identify individuals who want to discuss and document life-sustaining treatment options, and to recognize situations such as terminal conditions, progressive medical instability, or irreversible decline in function that warrant the discussion of these options and documentation of choices, regardless of whether this has been done previously. If a patient or authorized decision maker are not aware of the need to have such discussions, or they don't raise the subject with the provider or practitioner, then the practitioner or provider should give the patient or authorized decision maker the opportunity to participate. The second step in the process is to identify and obtain existing care instructions. Some of these decisions have already been made and documented. For example, someone who has just been hospitalized may have already had discussions during their hospitalization about cardiopulmonary resuscitation and the scope of subsequent medical treatment. They may have an advance directive, or they may arrive at another setting with an existing MOLST order form. Any existing MOLST form should be reviewed at some time during the admissions process. At other times, individuals who have been receiving care, for example in a dialysis center or post-acute care facility, or living in a setting such as assisted living, will have a change of heart or a change of condition, or both. So one objective of this step number 2 is to identify the written care instructions and orders and previously made decisions related to life-sustaining treatments. And another objective is to start identifying a patient's general goals of care and their explicit and implicit values and wishes. Another objective of Step 2 is to inform patients or an authorized decision maker of their rights to have input into medical treatment decisions and to participate in advanced care planning. This is based on federal and state laws such as the Patient Self-Determination Act and the Healthcare Decisions Act that require such notification. In each care setting, someone should be assigned the responsibility to transfer copies of documents to those needing them and to place those copies in the medical record. It's important to clarify the content and implications of any document such as advance directives and MOLST forms or a healthcare decision-making worksheet, and related information that's obtained from the patient or an authorized decision maker or another setting where the patient has previously received care. Advance directives may be general or vague, or they may place conditions on the implementation of specific choices, and they don't necessarily cover all relevant situations. Patients and their families may not be fully aware of the content or clear about the implications of their own advanced care planning documents or those of the person for whom they are acting. Healthcare choices in advance directives are usually more general and situation-specific. For example, a situation-specific directive might request that aggressive medical interventions, including life-sustaining treatments, not be used if they are deemed to no longer be likely to make a difference in the outcome or improve function or quality of life. On the other hand, a choice on the healthcare decision-making worksheet will likely be more treatment-specific. For example, that the patient wants a time-limited trial of artificial ventilation for a specified period of time. The bottom line is that many patients and authorized decision makers will need information and guidance on the procedures related to MOLST and advanced care planning, including how and where to document their wishes. Healthcare professionals and staff other than physicians and nurse practitioners can do much of the job of identifying and clarifying existing wishes, goals, and values, and thereby help the physician or nurse practitioner who must discuss the options and write the orders. However, general advice and support is not the same as discussing and choosing specific treatment options. So clarifying existing information, which usually does not need a practitioner's involvement, contrasts with advising people about which decisions to make, which is definitely the practitioner's responsibility. So it's recommended that each setting adopt policies that clarify these responsibilities and establish accountability for meeting them. Step number 3 in the process is to clarify relevant medical issues. This step is essential for identifying situations where life-sustaining treatments are potentially relevant, as well as their impact on the patient's function and quality of life, consistent with their values, wishes, and goals. The World Health Organization defines health as, quote, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, unquote. So medical conditions clearly affect function and quality of life, and vice versa. Understanding problems and prospects is a key starting point for identifying benefits, risks, and pertinence of potential life-sustaining treatments. As stated succinctly in the classic reference de Gouwen's diagnostic examination, quote, accurate diagnosis precedes the three tasks central to the healing professions: explanation, prognostication, and therapy. They provide answers to the patient's three fundamental questions. 1. What is happening to me and why? 2. What does this mean for my future? And 3. What can be done about it, and how will that change my future? Unquote. So the practitioner is primarily responsible for clarifying the current medical situation along these lines and its implications for the patient's quality of life, function, and prognosis. For instance, how likely is a patient who has had multiple hospitalizations for recurrent acute respiratory failure to stabilize, improve, decline, or die, both in the short term and in the months ahead? This step number 3 also calls upon practitioners and providers to use their skills to apply existing knowledge about illness in general and to match it with their understanding of the facts about individual patients. A good term to describe this is context, meaning that life-sustaining treatment options should be offered and provided in context. Despite challenges, it's often possible to establish a most likely course or outcome. Prognosis determination is based on likelihood, not certainty. There's considerable evidence about factors that predict poorer outcomes. For example, having multiple unstable coexisting medical conditions or recurrent hospitalization within the past 6 months. A portion of the Healthcare Professional's Guide on the MOLST website offers practitioners an example of how they might summarize their opinions and conclusions to guide patients, authorized decision-makers, and staff about these issues. Step 4 in the process is to define the patient's decision-making capacity. Decision-making capacity is a functional capability that's influenced by medical conditions and various functional and psychosocial factors, such as background and education. So decision-making capacity is not the same as cognition or mental status. A single test or assessment result is generally not definitive, and decision-making capacity is not always all or none. It can be partial at several levels. It also can be determined by a clinical assessment and does not require judicial determination of competence. The determination of decision-making capacity is essential to optimize the individual's participation in personal and healthcare decisions. Since certifications related to decision-making capacity can have major implications for a patient's subsequent opportunities to influence his or her care, the responsibility to assess and make conclusions about this should be taken very seriously. Not infrequently, patients have partial or fluctuating decision-making capacity, or they have experienced recent changes in that capacity, often due to potentially correctable underlying causes such as acute illness or adverse medication effects. To the greatest extent possible, decision-making capacity determination should be based on performance over time and not just one occasion or episode. It's also important to inquire about previous levels of decision-making capacity and recent changes in such capacity. Of course, it's also recognized that this information is not always readily available or clear. This step is certainly one area for potential improvement in conjunction with the implementation of MOLST. While physicians must certify the lack of decision-making capacity, they clearly vary in understanding the concept and the criteria for determining it. Decision-making capacity can fluctuate, and it may improve or decline with time or as new factors and conditions arise. This entire step is yet another example of the importance of coordination among various professional disciplines. In this case, to gather and interpret information that can be used to determine decision-making capacity. For instance, it's helpful to see how someone responds to various situations, both simple and more complex, the consistency and pertinence of their responses over time, and things that may impede their appropriate responses, such as limited vision or hearing. It is important to establish a common perspective about an individual's decision-making capacity. For example, so everyone knows whether or not to accept the attempted decision-making of someone else on behalf of the patient. While these determinations of capacity are often straightforward, opinions may be contrasting and equivocal. Various evaluators may use different assessment criteria. So it's useful to look at some of the published guidance about determining decision-making capacity. For instance, the literature has suggested 4 performance levels related to these determinations, including, number 1, evidencing a choice, which is the most basic level. Number 2, factual awareness of the issues. 3, rational manipulation of information. And 4, appreciation of the nature of the situation. It's useful for anyone who's involved in capacity determination to familiarize themselves with these criteria and the processes. Because of these many diverse factors related to determining decision-making capacity, it's essential to document a basis for the conclusions about a patient's capacity and to reconcile different opinions. It's also important to reassess capacity over time as the situation warrants. For example, a change in condition, a new onset of confusion, or improvement in mental status and function, or the request by either the patient or someone else to change the orders on the MOLST form. Since loss of decision-making capacity has profound implications for anyone's participation in making decisions that affect their life and health, it's important to identify and address factors affecting decision-making capacity, such as underlying causes of lethargy, confusion, and impaired attention. For instance, delirium is a common condition in individuals who have a recent change in mental function and level of consciousness. Delirium refers to acute brain failure due to medical causes, and it typically presents with psychiatric symptoms and a fluctuating level of consciousness. It has many diverse causes, some of which can be identified and addressed. Many medications in almost every category can directly or indirectly affect brain function. Often, medication combinations are more problematic than any one medication alone. And especially in elderly individuals and those who have had a recent or marked change or fluctuation in their level of consciousness, thinking, communication, or behavior, medication-related complications and medical conditions such as hypothyroidism and fluid and electrolyte imbalance are very common and deserve consideration. Even when individuals have partially impaired decision-making capacity, it can be fruitful and pertinent to consider their input about treatment decisions. For instance, a patient who cannot readily discuss the rationale for whether he or she wants a feeding tube may still try to pull out an indwelling tube or repeatedly state, "I don't want it." So based on these preceding considerations, it's vital to clarify each patient's role in making healthcare decisions, based in part on decision-making capacity determinations. It's important for every setting and organization involved in MOLST to develop or review their policies and procedures about decision-making capacity determination and documentation, and also to have some performance improvement criteria for reviewing how well these determinations are made and documented. A capable patient has the right to make decisions on their own behalf, but if they lack decision-making capacity, then the Healthcare Decisions Act specifies a sequence of involvement as well as restrictions and process requirements for substitute decision makers. In every healthcare setting, someone ought to know this aspect of the law so that they can guide and review staff and practitioners and how they do this in individual cases. It's also important to beware of claims to be someone's authorized decision maker without valid documents that support that claim. For example, whether they were or say they were appointed as an agent, or whether their place in the succession is consistent with the law. It's also important to resist the pressure or threats from individuals who are not the primary decision maker. For example, family members who are not in the proper sequence but who try to override the wishes of a capable patient, or relatives who try to override another substitute decision maker. The role of any substitute decision maker, referred to as authorized decision makers under the MOLST form and related materials, is to make decisions on behalf of someone else by considering the person's explicit and implicit wishes and their best interests, as well as relevant medical information and guidance about the pertinence of potential life-sustaining treatment options. That's a lot to expect of people, many of whom are thrust into their roles with little background or warning. So they're going to need help regarding the related procedures and their roles and responsibilities. For instance, they should know that under the law, substitute decision makers cannot just impose their personal values or choices, and they can't simply override someone's expressed and documented wishes and substitute their own. They're also going to need guidance to understand the facts of a patient's situation and the potential benefits and risks of various life-sustaining treatment options. So the MOLST website includes guides, slides, and other resources for these authorized decision makers as well as for patients. There's also a healthcare decision-making worksheet that both patients and authorized decision makers can use, along with detailed information about the meaning and implications of making various choices. It's important to document the basis for designating a primary decision maker. That is, how did you choose that person, consistent with determining the patient's decision-making capacity and with the law about succession. For instance, someone with a higher priority was unwilling or unable to make decisions. Sometimes the correct primary decision maker is clear. For example, when a patient who lacks capacity is already appointed an agent in an advance directive. But as you know, we face a number of challenges in choosing substitute decision makers when the patient lacks capacity. In any setting, a consistent, organized approach to handling these challenges helps avoid problems that may adversely affect the goals of making decisions to best reflect the patient's wishes and needs and condition. For example, substitute decision makers may be unavailable, unwilling, or unable to make decisions, and the Healthcare Decisions Act lumps all of these under the category of being unavailable. There may be conflicts within a class of substitute decision makers, for example, children or siblings, or among those of several categories. There may be multiple claims to being the substitute decision maker, or there may not even be an identifiable substitute decision maker. Again, it is important to note that the Healthcare Decisions Act confers legal immunity for decisions made in good faith, including those related to the selection and communication with a substitute decision maker in conjunction with the law's prescribed processes. Step 6 involves identifying and certifying conditions as defined under the Healthcare Decisions Act, specifically terminal, end-stage, or persistent vegetative state. The Healthcare Decisions Act requires that one of these conditions exist in order to allow a surrogate decision maker, that is, an authorized decision maker not appointed by the patient, but who assumes the role by default, to make decisions to withhold or withdraw life-sustaining treatments. And in addition to allowing for this kind of decision-making under certain circumstances, the determination of qualifying conditions also helps to provide an overview of a patient's overall condition and prognosis. It is important to follow the Healthcare Decisions Act definitions. Terminal or end stage relates to an individual's overall condition, including the aggregate of their burdens of illness and impaired function. It's possible to be in a terminal or end stage condition despite not being able to identify one single illness or condition, or not having an end stage condition under the law despite having end stage organ failure such as end stage liver or kidney disease. As with other aspects of healthcare decision-making, the designation of a qualifying condition must often be based on probability, not certainty. So it's helpful to document the basis for conclusions about qualifying conditions, since others may need to understand the basis for such determinations. Step 7 is to define and present healthcare options and issues. So after all of the preceding steps, we now reach the point of defining and discussing life-sustaining treatment options with the patient or the patient's authorized decision-maker. Obviously, it's not always possible to follow the preceding steps fully or in the exact sequence. How much time we have to be able to spend on any step in the process or in the entire process will depend on the setting and the situation. And yet, despite these time constraints and the pressures of emergency situations, it's crucial to define the issues as best we can and as clearly as possible before presenting and addressing them. A good term here to describe Step 7 is, again, convergence. As this slide illustrates, the identification and presentation of life-sustaining treatment options reflects the convergence of several paths. One path is the identification and clarification of patient values, wishes, goals, and treatment choices. The other path includes medical considerations, including the patient's medical condition and prognosis, as well as the indications, availability, and potential effectiveness and risks and benefits of life-sustaining treatment options. This Step 7 should include more than just offering treatment options. People often need time and support from various sources, such as staff, practitioners, family, friends, and clergy, to make these decisions. It's also useful to guide the patient or the authorized decision-maker to match the potential treatment options with their goals, wishes, and values. The MOLST website includes several items to promote these discussions, including recommended questions for patients and substitute decision-makers to ask, worksheets for summarizing medical opinions, more detailed discussion of the meaning and implication of choosing various treatment options, and slides and written materials that summarize what will happen when life-sustaining treatments are given. To help do the best possible job at Step 7, it's important to define issues concisely and accurately. For example, the scope of the patient's decision-making capacity, including ability to consent to and cooperate with tests and procedures. Options related to addressing inadequate food intake, including in the light of underlying treatable or untreatable causes, prior to considering artificial nutrition and hydration. The potential benefits and limits of CPR in light of the underlying causes of illness and the likely impact on function and quality of life of surviving CPR. How the information is presented may influence how the primary decision-maker understands issues and makes decisions. The literature identifies more or less successful ways to do so. Again, the healthcare decision-making worksheet and related, more detailed discussion of specific treatment items on the MOLST website can help the staff and practitioners guide patients and authorized decision-makers to match treatment options with the medical information that is given to them. In many situations, potential treatments will not change the course of someone's condition or materially improve their outcome. The healthcare practitioner is not obliged to provide a treatment that he or she considers medically ineffective or not in the patient's best interest in the context of their wishes, goals, and values. However, the practitioner and provider must follow procedures in the Healthcare Decisions Act if they determine that they are unwilling or unable to follow the requested course of treatment based on such considerations. The medical literature contains considerable evidence about interventions that are more or less likely to affect outcomes in various situations. For instance, cardiopulmonary resuscitation is more likely to be effective when there is a serious arrhythmia or another reversible cause of cardiopulmonary arrest, and it's unlikely to be effective when death is the result of the impact of age and or advanced irreversible medical conditions. It's useful for all settings to obtain and refer to some of this literature, both for the practitioners who must decide which options to recommend, and for staff who may be involved in these processes, as well as patients and substitute decision-makers who have to make choices about life-sustaining treatment options. It may take repeated efforts by multiple individuals before patients or authorized decision-makers make decisions that appear to be consistent with the facts. It's important to document the basis for recommending various treatment options. Again, the MOLST website contains a worksheet, slides, and other written materials to help practitioners summarize condition and prognosis based on the anticipated course of a patient's condition, as well as knowledge of the potential impact of various treatment options in similar situations. A systematic approach to presenting and documenting treatment issues is an important risk management measure, as the law confers immunity regarding decisions and recommendations made in good faith and in accordance with the procedures prescribed in the Act. In contrast, haphazard processes inconsistent with the Healthcare Decisions Act may be more likely to expose a facility, organization, or practitioner to a risk of legal and other complications. Now we come to Step 8, which is to actually write orders and implement those orders regarding specific life-sustaining treatments. Orders should at least cover CPR, as well as any other situations where treatment choices have been made or are needed. Keep in mind that orders related to CPR on page 1 of the MOLST form apply both for the setting in which the patient resides or is receiving care and for any situations where EMS personnel are involved in a person's care. EMS personnel will always follow the MIMS protocols, while each setting will follow its own protocols as to what specific interventions it will initiate. For instance, hospitals and a few other settings can provide a full range of treatment for those who have cardiopulmonary arrest, while other settings will initiate the most basic measures and then summon EMS support to treat the patient and transport them elsewhere for continuing care. As with the presentation of treatment options, the MOLST orders themselves ultimately reflect the convergence of the same two paths. One is what the patient wishes and authorizes, or what a substitute decision-maker authorizes on their behalf. The other path reflects the medical facts, including the condition and prognosis and the indications, availability, pertinence, and potential effectiveness and risks of various treatment options in the proper context. So ultimately, the MOLST orders result from balancing these diverse factors with the goal of trying to attain the best possible results for the patient under often challenging and uncertain circumstances. This sounds difficult, and it is, but it can be done well. Don't confuse CPR status with treatment prior to arrest. Code status doesn't automatically equate with the scope of treatment warranted prior to arrest or with the need to hospitalize for illness. Wanting other interventions prior to arrest does not automatically mean someone wants CPR, and wanting CPR doesn't automatically imply that they want or need other treatment when cardiopulmonary arrest is not imminent. Note that the MOLST materials guide patients and authorized decision-makers regarding the meaning and implications of each treatment option. Choosing a treatment option only authorizes its use if medically indicated and does not mandate giving a treatment regardless of its medical implications. As we've noted, practitioners also can decline to give treatments that they consider to be medically ineffective, although they have to follow the specified procedures before they implement orders not to give treatments based on medical ineffectiveness. So step number 9 involves the periodic reevaluation of the patient and the patient's situation regarding life-sustaining treatment options and related documents, including the MOLST orders. This last step in the healthcare decision-making process is actually recycling of previous steps to the greatest extent possible, given the challenges, including time constraints. This step number 9 involves reaffirming patient goals, wishes, and values, reconsidering the patient's medical condition and prognosis, and reassessing the need to consider or reconsider various treatment options. Of course, it's possible that little, if any, of this has changed over time, in which case we would just reaffirm that previous determinations and conditions still exist. People's medical condition and function often changes with time, and patients can change their mind about their goals and wishes for treatment. They may change their authorization for current orders on the MOLST form, or their advance directives, or both. It's important to review or confirm a patient's decision-making capacity prior to accepting or making changes or revocations. If an authorized decision-maker is proposing to make such changes on behalf of a patient who lacks capacity, it's important to identify that they are still acting within the scope of the patient's wishes, including any instructions or authority that the patient gave them to act on their behalf. For instance, an authorized decision maker cannot simply decide to instruct a practitioner to order treatment or change MOLST orders in a way that contradicts a patient's explicit wishes. In the absence of clear direction from the patient, an authorized decision maker is supposed to consider their best interests from the patient's perspective. That is, what interventions or withholding or withdrawing of interventions would be consistent with the patient's previously expressed goals and wishes to the extent that we are able to know and clarify them. As we have discussed during this session, healthcare decision-making is a complex process involving significant challenges. For those who've already been using a consistent healthcare decision-making process, such as the one we've reviewed, the implementation of the new MOLST form will be relatively straightforward and painless. After all, it doesn't change the underlying decision-making processes, but it does provide a new and hopefully clearer and more consistent way to document life-sustaining treatment orders. For others, the challenge of using the MOLST form will be compounded by the need to implement or revamp some or all of their healthcare decision-making process. The good news is that this process is both universal and enduring. It works everywhere. And once it's done properly, it works well over time, and most implementation will be relatively straightforward. So we recommend that each setting strategize to use its personnel and resources to implement these processes consistently. Of course, each setting has various advantages and challenges. For example, nursing homes generally have more time than hospitals do to gather information and make these decisions, and they have enough presence of social services staff to be able to coordinate many aspects of the process. On the other hand, hospitals have more resources and practitioners to diagnose causes of condition changes and establish a patient's prognosis. In any setting, families, patient advocates, clergy, and others may be able to help guide patients and authorized decision makers and support effective decision-making processes. The Patient Care Advisory Committee or an equivalent can also help guide staff and practitioners and patients regarding complex or problematic cases. It's recommended that every setting in which MOLST is to be used establish organizational policies and procedures to promote and standardize this healthcare decision-making process as well as compliance with the MOLST requirements. There are many opportunities in each setting while providing care or service to make and document information that can facilitate subsequent decision-making capacity determination. For example, observing mood, behavior, and thought processes, listening to someone explain their thinking about a variety of things, and asking the individual the basis for their conclusions about actual or hypothetical situations. This is an example of how we can incorporate the steps in this decision-making process into everyday activities instead of seeing them as an extra burden that only arises when a form needs to be completed or decisions need to be made. In every setting, it's important to assign responsibilities such as obtaining copies of advance directives, reviewing existing MOLST orders, and determining decision-making capacity. As with any activity or process that needs to be done in a certain way, it's likely to be fruitful to establish a performance improvement activity related to the entire process and its components. For instance, are the legal requirements being followed correctly? Is decision-making capacity determination being done consistently and documented effectively? Are specific individuals involved in the process fulfilling their roles consistently? And is the MOLST form being completed, revised, and transferred correctly? There's an extensive literature about bioethics principles and patient rights. However, there's relatively little detail out there about the decision-making process as a whole and about strategies to try to improve performance and practice by organizations and individual healthcare professionals, including physicians. So this and the final slide lists some publications that cover these process and performance issues in greater depth. Some of them are available online, and all of them may be obtained upon request to Dr. Levenson at salanlev@comcast.net. Here are several additional references. Also noteworthy is that the issue of Maryland medicine cited on this slide is an entire issue about end-of-life care and various aspects written by a number of individuals from different perspectives. It is recommended to your attention as a good reference and resource for training and educating physicians and others about the process and their roles in making these decisions. The implementation of the Maryland MOLST form is an opportunity for all of us to look at how we make, document, and implement decisions about life-sustaining treatments, and to consider how we can use this new MOLST tool to improve our processes and thereby hopefully optimize the results for all of those who we care for in Maryland.